So he was a 50 years old male and he had cervical PID, C5, C6 with neurological deficit. He had myelopathic signs, and you can see there is significantly compressed spinal cord there. And straightforward case it appeared to, and we did discectomy and fusion, and we used to put only the bone graft because there was no instability, and we never plated such patient earlier. This is I am talking about in 94, 95. So everything was fine. Then he took full diet till 7th post-operative day. On 8th post-operative day, he had dysphagia, odynophagia and neck swelling. And we took the plain X-ray. You can see the pre-vertebral shadow earlier was like, and now it has appeared like this. So there is a significant increase in the size of this pre-vertebral shadow, and that created a doubt. So 2 stitches were opened up and there was a mucopurulent frothy discharge. The methylene blue test was positive. We used to put in the oropharynx, and since we have opened the wound there, that the methylene blue, it came out through the wound, so there was a staining there. So it was confirmed that this is esophageal perforation, and general surgeon's opinion was taken and he advised re-exploration. And the general surgeon came and started doing this. So there was a disaster during re-exploration. So search of minor leak, there was 2 centimeter tear. Because 7th, 8th day the edema is there. In searching that, there was 2 centimeter of the opening. And the general surgeon planned a diversion at a later date. He put Rice tube in the distal esophagus through the neck wound. Antibiotics and dressing continued for 4 days, and this 4 days was 4 decades for me, and it was very agonizing and it was a rough phase of my life. The patient's physical agony was significant. He had significant odynophagia. Deglutition of saliva was impossible, and there was excessive salivation. So at the head end of his bed, there are a lot of gauze pieces kept. He used to just wipe continuously. On 13th post-operative day, he developed toxic symptoms. That was the 5th day of the re-exploration, and he died on 14th post-operative day, the 6th day of re-exploration. Now, death is a known complication, though it is not very common. But if you don't take care, they die of different issues. So it is very important to know what are the different causes and how to prevent them. That is very important. So the early causes are iatrogenic. So injury during intubation or nasogastric tube insertion. So we know these are the 2 important areas which is well described in literature, that is Killian's dehiscence and the V-shaped area of the lamar. So here what happened, between the cricopharyngeus proximally there is a narrow space where the muscles are not much. Even below that, where there is the area of lamar, that is also deficient in that area. So very thin layer of esophagus is there, and that is the common site of actually perforation. Injury during surgery. So these are the things which can happen. Your burr might slip, you might cauterize while putting the even drain tube. Sometimes you have habit of cutting the drain tube obliquely. So that pointed edge can lead to the late injury. And sometimes when you use this Casper retractor, this retractor, it comes out and suddenly your assistant, he presses. If there is nearby esophagus, it will be crushed. Always try to cover the esophagus either with a very good retractor. I usually put nowadays that gauze piece. You can see the wet gauze piece which is covering the esophagus, never the direct pressure. And the curved part of your retractor should be lying beneath the longus colli muscle. So that is extremely important. Now, esophageal wall ischemia can happen. This happens usually in late leak, which was in this case, in my case, where it happened after 7 days. So this is because of the pressure necrosis. In the late, we are aware that all these prominent implant, backed out implant and graft can lead to pressure necrosis, and there may be esophageal leak. Now, this is very important. I stress this point. Sometimes you deal with the traumatic cervical column injury, and you don't think about, you go ahead and you do the fixation. But sometimes there is a pre-existing esophageal injury also when this trauma of the cervical column has happened. So I had a case, I will be showing that. So it is the initial trauma, and the literature is full of this post-traumatic cervical column injury leading to esophageal injury, and all these cases are well mentioned in the literature. So what is the common scenario? You get a cervical spine fracture or fracture dislocation, and patient comes to you with the quadriparesis or plagia. So you reduces, you decompress, and you stabilize. But post-operative, what you find, sometimes there is a wound dehiscence, and you think this is the post-operative infection, and you start tackling that part, thinking a simple wound infection. Or sometimes the patients become toxic, there is a bad chest, and he dies, and you think this is the actually sequelae of quadriplegia. There is a respiratory paralysis, and you think that because of that he died. But sometimes the minor leak might go unnoticed unless you pay attention to these patients. Now, this is the patient which who presented to us, and you can see this is the extension type of injury. There was a cord injury, edema was there. There is a hyperextension injury, and we plated, and he had this leak because there was a swelling which appeared in the neck area. This is the barium swallow, and this showed clear-cut leak there. Okay, and now you see, we went again to its images, and you see this piece has actually caused trauma to the MRI. You can see in the MRI, esophagus. It is nicely visible here, but we did not notice it prior. It was noticed later on when we started subsequently searching the thing. The cause of death is usually mediastinitis, septicemia, or meningitis. The incidence of perforation is 0.02 to 1.49%, but if it happens, it can lead to mortality from 6 to 18%. They have very high mortality if it happens. Okay, and how will you manage these cases? Approach to such a case, you have to have the diagnosis. You have to confirm it with this methylene blue test, or you do contrast esophagography. Even the CT can help you. You will find the air shadow in the surrounding area. And endoscopic examination, you can have the clearly visible things if it already perforated, and you can see this. All these things have been mentioned in the literature quite widely. And sometime while if you are exploring, it is better to put rice through the rice tube or some tube. Intraoperatively, you can detect the tear. The methylene will start coming from that part. Okay, so this makes everything simple. Now, what is the treatment of this perforation? It is controversial, aggressive versus conservative, and highly case specific. It will depend what is the situation, and most of the time you will be able to actually control it and treat it nicely. So when you are going to treat it or consider treatment by conservative means, if the defect is contained or there is a no contamination of the pleural area or mediastinum, and there is no signs of septicemia. The defect is very minor. You can treat it conservatively by stopping the oral feed. You start rice tube feeding. High calorie diet is to be given through this tube. You can put egg chips and protein and all this. Never through the neck, which was done earlier. It is never to be done. Intravenous sensitive antibiotic is started, mostly the broad spectrum antibiotic. Do the liberal wound drainage. You just keep it open, everything will come out. Since you have stopped the oral feed, it heals very nicely. Now in this case, the second case which I showed, this healed very nicely. Then you do the keep the patient under observation. Maybe after a week or so you start, but don't start liquid. Start with the semi-solid. That patient used to take a lot of biscuits, okay, and you can ask him to take even chapati after proper chewing. So that area is still draining. So you keep it is under observation if something is coming. So first you start semi-solid and start liquid after 2 weeks, and it heals nicely. What is the surgical treatment? Primary repair should be done by the first surgeon who has operated, because you know the plane properly. If you wish to call some GI surgeon, it is better you also be there so that you can guide him also. And you can do the flap reinforcement after suturing the wall of the esophagus, and that different nearby muscles which can be utilized. The sternocleidomastoid is used very commonly. You can use the longus colli, and there are other all different muscles which are nearby can be utilized. In the literature, the use of jejunum, omentum, pleura, platysma, all these things have been actually described and has been used. So this is a very common thing in sternocleidomastoid. In that case, we did it. So you have to just turn the sternocleidomastoid part of it, you turn from here, because the attachment is from sternum to mastoid process. So you turn it, bring it there and put on that suture part. So this is a flap which is covering that area. You can also use pectoralis major flap, and this most of the time it heals and there is not a problem. So I'll conclude the high suspicion, early detection and prompt treatment. Usually you will get this fruitful outcome in a case of esophageal perforation. The suspicion is extremely important, and I think if you have a close observation, there should not be any problem. I thank you very much for your kind attention.